Okay, now we about to commence the second session of pathology. And in this session, we have two more very exciting lectures, and Dr. Umar will moderate this session. Over to Dr. Umar.
Yeah, thank you, Dr. Mudassir. Okay, so welcome back to the last session of pathology at this cancer symposium. So our first speaker is Dr. Abbas Agemi. He's a professor of pathology and deputy director at the Department of Pathology in Friedrich Alexander, Germany. He is expert in many fields, but his special interest lies in head and neck tumors of pathology. So he will be giving us a talk on head and neck pathology 2022 WHO updates. Dr. Abbas Agemi is very well published, and he has published over 300 articles and many book chapters. So let's begin with Dr. Agemi's lecture.
Yeah, Dr. Mudassir, dear colleagues, thank you very much for inviting me to participate in this Shaukat Khanum Memorial Cancer Symposium. I have very much wished to be attending in person, but unfortunately, because of parallel commitments, it was not possible for me to attend. So I will record for you my talk and hope that everything would be technically okay and you hear me well and understand and see me well. So my talk is mostly devoted to updates on the recent WHO classification of head and neck neoplasm, which is now under the way to be printed, and we hope that we get the hard copy very soon. I just like to go over a very few basic information regarding the recent development in head and neck pathology. And this is the list of the old salivary gland tumor classification from the last WHO classification. And since that classification in 2016, we have several new developments, many of them concern existing entities. However, we have also some new entities. So we have some new genetic features with regard to acinic cell carcinoma, to intraductal carcinoma, salivary duct carcinoma, and secretory carcinoma as well. We have some updating or increased controversy regarding ductal papillomas or intraductal proliferation, sclerosing polycystic adenosis, which is now moved from the non-neoplastic epithelial lesion category to the benign neoplastic lesion category. So it is now called adenoma and not adenosis. Oncocytic carcinoma has been a topic of controversial discussion, and now most authors agree that this is not really a specific entity, but a variant of many other definable entities like mucoepidermoid and salivary duct carcinoma. So this category has been omitted now and put into an emerging or so-called emerging category, and I'm sure it will be removed the next time. Pleomorphic adenoma, we have very few new genetic data on that, of course. And this is just to highlight the removal of the oncocytic carcinoma. So please do not make this diagnosis anymore, and be sure that any oncocytic looking definitely malignant salivary carcinoma can be defined as another specific entity by a lot of tools, including immunohistochemistry and molecular testing as well. With regard to the 2022 WHO classification, we have now a new listing. We have 3 new malignant entities. These are microsecretory carcinoma or adenocarcinoma, mucinous adenocarcinoma, and sclerosing microcystic adenocarcinoma. We also have 4 new benign lesions. These are intercalated duct adenoma and hyperplasia. We have been using the non-committed terminology intercalated duct lesion in the last years now. It can be defined as either hyperplasia which is more or less corresponding to intercalated duct lesions in the past, or the encapsulated, very well circumscribed type can be called adenoma. The striated duct adenoma now is included as a true benign neoplasm. Even after the WHO classification, we have reported a very high frequency of IDH mutation in these entities. So this is a definite entity now, also in the post-WHO classification literature. As I said, sclerosing polycystic adenoma now is the official name for what has been called adenosis. And keratocystoma is a very rare lesion that has been included in one of the previous versions of the WHO classification now, and then it has been removed. Now it has been again accepted as an entity. Regarding actinic cell carcinoma, there is really very major or important recent developments, which is the clarification of the genetic background of these tumors that have been of unknown molecular pathogenesis, although the diagnosis is straightforward. And we are very lucky to be the first group to highlight the genetic background of this relatively common variant of salivary gland carcinomas. We using whole genome sequencing and several types of molecular evaluation testing, we could decipher the background of these tumors, in which we reported a very high frequency approaching maybe 98% of cases of a gene translocation T49, which is not a very classical gene fusion. We do not have a chimeric protein or fusion transcript, but there is removal of some of the enhancer genes from one region on chromosome 4 to an area up front or ahead of the NR4A3 gene, which is a non-oncogene. We all know its role in extraskeletal myxoid chondrosarcoma and some other entities. And this translocation then results in overexpression of NR4A3 due to the overexpression of its enhancer as a consequence of this translocation. And as I said, there is no fusion oncogene in this type of translocation. So when we perform classical NGS RNA-based, the result usually will come negative because no fusion transcript is formed. However, we then tested the possibility of a commercially available antibody against NR4A3 or NOR1. And indeed, we are very lucky to have it very well functioning, and we detected expression of this protein or antibody in almost 98% of all actinic cell carcinomas. In my experience, it is even much more than 98%, because since then I have never seen any single case that was negative. So this antibody with this type of very strict nuclear expression in every nucleus, this is almost pathognomonic for actinic cell carcinoma of the salivary gland. Some type of cytoplasmic staining may be seen in some other entities like secretory carcinoma, but the strictly clean nuclear expression is pathognomonic for actinic cell carcinoma. Very focal, weak to moderate expression has been reported in variants of mucoepidermoid carcinoma that was called mucoacinar mucoepidermoid carcinoma. So it seems that this expression in subsets of mucoepidermoid carcinoma may correlate with focal serous acinar type differentiation as a mixed pattern of differentiation in that very rare subtypes of mucoepidermoid carcinoma. You see here another example of intercalated duct type microcystic variants of actinic cell carcinoma with prominent lymphoid background. This lesion, if undergoing FNA, may be almost impossible to diagnose previously because it looks like salivary inclusion or benign inclusion within lymph nodes. However, now we can verify its neoplastic nature again by the NR4A3 antibody, which is very well functioning, and we can confirm this is indeed actinic cell carcinoma. So this antibody really is very good for cytology in this case. Another very useful utility of this antibody is that cases of acidic cell carcinoma with dedifferentiation or high-grade transformation, if they are biopsied, it can be, of course, confirmed as being acidic cell in origin using the antibody as well. With regard to the secretory carcinoma, really there is no too much new information. However, yes, I like to highlight for you this very pitfall situation, which is reported by Bruce Benning, a series of macrocystic or unicystic macrocystic secretory carcinoma that many of these lesions may be missed as being a banal salivary duct cyst, so we have to be aware of that entity. These are demographically very similar to classical secretory carcinomas, and as you see, most of them were unicystic, so they really look like simple salivary duct cysts. However, they have intercalated type epithelial lining, they have multi layering of the epithelial lining, and still, of course, some of them have peripheral B63 positive layer. So it seems that some of them indeed are intraductal cystic growth of secretory carcinoma, and 1 of 4 cases with long follow-up recurred locally. So we have to be careful about this. These are examples of this type of secretory carcinoma, as you see here, very large, simple-looking cyst. However, we have some areas with solid fragments floating into the cyst lumen, or adherent to the cystic wall, or it can look like multicystic simple cyst adenoma. Here you see also the lining is very deceptively blunt. This is one of the cases I have seen myself, and you see again, it looks very much like either intraductal papillary lesion, or even it looks like intercalated duct type intraductal carcinoma with this small acinar-like or papillary proliferation inside the cystic wall. If we look exactly to the immunophenotype, they recapitulates classical secretory carcinoma with co-expression of SOX10, S100, and nuclear reactivity, in this case for pan-Trk immune antibody, which is very consistent with the classical ETV6 anti-RK3 fusion in these tumors. Now, a very few worked on salivary duct carcinoma. There is not too much new information. However, we and very few other reports have shown that a small subset of salivary duct carcinoma indeed harbor ALK fusions. And this is also a minor subset of these highly aggressive tumors. Of course, it is very important to recognize because they are very relevant for targeted therapies in case that the patient develop metastasis. If you see here in our paper published in AGSP, we reviewed all cases reported, and we reported 4 cases. And we see that most cases of salivary carcinomas with ALK fusions were either intercalated type intraductal low-grade adenocarcinomas or salivary duct carcinomas that may be classic looking or atypical looking, and I will explain to you why they look atypical. And you see here that the fusion is not different from what we see in lung adenocarcinoma. So EML4 ALK or STRN ALK, and rarely some other rare fusion variants. This is one of our cases. You see, it looks really like what we used to call earlier basal-like or basal-type salivary duct carcinoma. So it looks like very basaloid. However, we see an admixture of basocolumnar or cylindrical epithelial proliferation. At the periphery, we have some squamoid or basal cell-like component, and to the lumen, we have some micropapillary or papillary-looking adenocarcinoma-like component, very extensive necrosis, as we see in salivary duct carcinoma. Intraductal growth is seen as well, and also similar to other types of ALK rearranged carcinomas, there is some stromal or luminal mucin type secretion, as we see here. This is one of the cases that look very much aggressive with single cell invasive growth pattern, can be easily missed for poorly differentiated or poorly cohesive squamous cell or salivary duct carcinoma. This is another example showing two components. One of them is classical apocrine type intraductal salivary duct carcinoma, and the invasive component was much more basal-like, looking more basophilic. And you see here the intraductal growth highlighted by P63. And again, here, even in the invasive looking component, there is a variable intraductal component. These tumors, as I have shown, they have two population very closely admixed, a basal squamous-like proliferation, a luminal type proliferation, and here cytokeratin 5 highlights the two with expression in the peripheral component, sparing the luminal classical ductal epithelial component. Here you see that androgen receptor is very limited, so these are basal-like androgen receptor poor lesions. And if we look at CK5 in the invasive component, it is rather much more diffusely expressed. The ALK antibody, which is an interesting observation, highlights both components. So this is not just a collision tumor of two different entities, but this is a driver mutation or fusion that has already occurred in the non-invasive classical apocrine type intraductal salivary duct carcinoma component and is retained in the invasive, poorly differentiated basal-looking component. So this is a very new development in these tumors. Now coming to the new entities included in the WHO classification, which is now very recently coming, we see that microcystic sclerosing adenocarcinoma, microsecretory adenocarcinoma, mucinous adenocarcinoma, and I am not going to speak about the benign lesions, but only the malignant one. Sclerosing microcystic adenocarcinoma of the head and neck and neoplasm, that is already was reported parallel to the previous WHO classification in a series that I have contributed to. Indeed, it was reported before that, even long ago, but very few single case reports of the tongue and some other oral cavity sites. And these tumors really are very deceptive and difficult to recognize. They are highly infiltrating. They show up a biphasic population of ductal and myoepithelial cells. They have a dense sclerosed collagenous stroma in the background. At the end, they closely recapitulate microcystic adnexal carcinoma of the skin. So if you are aware of that skin entity, you can easily recognize these tumors in the mucosal and salivary sites in the head and neck. This is just the major characteristic of the series of 5 cases we reported 2016. Most patients are young to middle-aged adult, mostly females, mostly in the area of the tongue, but they may occur in the floor of the mouth or other areas. And you see that some of them recur locally, however, no metastasis has been reported before. This is a non-reported case I have seen 2 or 3 years ago from our ENT department. The patient has a polypoid oropharyngeal lesion in the ovular area, and you see that it is very deceptive looking. So if you have just a superficial biopsy, it is very difficult to diagnose it as such. So we have the normal maintained mucoid salivary lobules, the ectatic ducts here, and in between we have had, however, much increased amount of stromal tissue, and this is the most remarkable feature that we see at low power. When we go to the high power, we see that we have very slender communicating and branching trabeculotubular proliferation with some few tubules scattered in between or embedded inside these elongated trabeculae. And we see also some wrapping around the salivary lobules or even infiltration inside it. Another higher magnification image showing the details of the microtrabecular or corded pattern, and frequently we have at the end of the cords or in between this simple microcystic tubule. Here again, a very vascular rearrangement. In this case, you see it looks really very much like sclerosing sweat duct carcinoma or microcystic adnexal carcinoma of the skin. You can highlight the neoplastic lesion and its extent by a pankeratin immunostain, as you see here, with very glandular and intralobular infiltration, and here it looks really just like a reactive lesion. So this is a very difficult to recognize lesion. Some people, when thinking just superficially, they may think Is it similar to cyalometaplasia? No. You see here the comparison between the two. In cyalometaplasia, we have a replaced salivary lobule. The lobule is just as a lobule recognizable, but the salivary tissue is not recognizable anymore. You may have very few remnant glands in the center, but it looks like a squamous proliferation delimited from the surrounding salivary lobules. However, in microcystic sclerosing adenocarcinoma, we see that the lobules and their acinar or mucus cells are maintained. So this is a completely different situation compared to cyalometaplasia. Now moving to the next entity, which is microsecretory adenocarcinoma of the salivary gland. I have to admit, I'm not really very happy with the terminology of microsecretory because it really does not give a real sense. This is a microcystic lesion. It has a very distinctive microcystic pattern, which is very prototypical. However, the problem is that we have already the term microcystic in use for the entity I just have presented to you. So if we use the same term, this will be confusing. So microsecretory is still at least a well understandable term as an entity name. This is the largest series from different institutions following the first description by Justin Bishop in a series of 5 cases. Then later we collected a total of 24 cases also under his guidance. And we see that these are very low-grade malignancies. They have really a myoepithelial-like or indeterminate between myoepithelial-like and intercalated duct-like immunophenotype. Women are slightly overrepresented. The mean age is 49. The oral cavity is the main site, really, with almost no case or very few cases seen in non-oral sites. However, the skin seemed to be, during the last 3-4 years, the most frequently reported site in the literature. These tumors, they may show an irregular expression of S100, SOX10, P50, P63, and they all have exactly the same fusion, MEF2C SS18. There is one study highlighting that they can be detected or verified by the conventional SS18 fish probe we use for synovial sarcoma. In my opinion, this is a bit difficult than in synovial sarcoma cases, maybe due to the exact location of the breakpoint. So it is difficult to verify in all cases. Sometimes it looks like false negative. I mean, the fish testing, so NGS is the most reliable confirmatory test. To date, only one single case has been reported to develop lung metastases that were very slowly growing. However, no single case have recurred. This is from the pooled series that was published recently. You see here a relatively well circumscribed non-encapsulated lesion at low power covered by oral cavity mucosa. However, if you look at high power, you see 3 features or 2 features mainly of malignancy. One of them is irregular bordering and invasion between the salivary lobules or into the very glandular normal connective and fatty tissue. And here again, you see a prominent neurotropic growth, something that may remind us of what we see in targetoid perineural growth in polymorphous adenocarcinoma of the salivary gland. However, you see that the morphology is very uniformly microcystic. We have pseudovascular microcystic glands containing mucoid bluish secretion, not really true lumina, and surrounded or lined by flattened myoepithelial-like cells. Again, here another area showing the homogeneously microcystic patterns, a very distinctive or impressive bluish secretory material in this pseudolumina, and sometimes we have some micro cribriform-like features. This case really has been redefined as something different in a later study, but the time is not sufficient to go into details about this variant genetic type. You see here again the very reactive oral mucosa with pseudoepitheliomatous hypoplasia and prominent microcystic arrangement. Frequently we see some lymphoid follicle at the periphery of the lesion. The third entity, or the third and last, malignant entity in the new WHO classification is mucinous adenocarcinoma, which has been included in the old classification in the adenocarcinoma NOS category. This is a tumor that, to be simplified, you can think of any type of upper GI adenocarcinomas. All types of adenocarcinomas of the upper GI tract can be seen, including those with colloid morphology, with signet ring cell morphology, with intestinal type morphology, with any type of papillary, tubulopapillary, and solid growth pattern. They are unified by these mucinous phenotypes, and importantly, they lack cytokeratin 20 and CDX2, and instead are CK7 positive, so they do not fit any of the intestinal type adenocarcinoma of the head and neck, especially those of sinonasal cavities. They are unified in addition to their heterogeneous mucinous phenotype by the presence of this ACT1 E17K mutations. This gene mutation is defining feature of all these tumors. However, this is highlighted because it is an important point. All of them also include or show a P53 mutation, which is consistent with a malignant process. They can metastasize, of course, to lymph nodes. You see here the heterogeneous morphology, colloid mucinous carcinoma type. You see here intestinal and solid and mucinous type. You see here also a mixed pattern. And even in this area, you see two different components. One of them is mucinous carcinoma-like, less differentiated, highly aggressive pattern, covered by something that remind us of low-grade mucinous appendiceal neoplasm or IPMN of the pancreas or of the biliary tract. So I will come back to this because this highlighted area is really very interesting. And I assume that no P53 mutation will be detected in this component if one micro dissected the two components and tested them differently. This is the classical morphology of the aggressive, poorly cohesive and signet ring cell variant. You see mucicarmine histochemistry, showing the mucinous secretion. And these are included in that series also as mucinous adenocarcinomas. However, we see this is very blunt looking, really not invasive, very lamb-like, and here again, low-grade mucinous IPMN-like, even some gastric-like features, and very variable morphology, however. Before the description of mucinous adenocarcinoma as an entity, indeed, 2018, we have postulated the term intraductal papillary mucinous neoplasm, or IPMN, for a subset of minor salivary gland mucinous intraductal proliferations unified by the presence of this same gene mutations that we have seen just in mucinous adenocarcinoma. These are usually in the minor salivary gland. You see the mucosa here, very well demarcated, uninodular, unicystic, or multi focal along the ductal system. You see here again this minor salivary gland, well demarcated, variable cytological atypia with some mitotic figures as well, very much looking like gastric foveolar epithelial tissue. This is one of the cases showing a diffuse involvement of the ductal system of the minor salivary gland. Again, it looks very much like atypical ductal hypoplasia of the breast, or even gastric type or pancreatobiliary type low-grade IPMN. So this is really something that is intraductal, ductulocentric, and not invasive. And if we look at the literature, these lesions have been named by very different names. This is an example of what has been reported as ductal papilloma. It is exactly the same thing, yes, I have shown you as IPMN in our series, or as mucinous adenocarcinoma in Bishop series. Another study calling them mucinous cyst adenomas, exactly the same lesion. Another study calling them also mucinous cyst adenoma, or even mucinous cyst adenocarcinoma. So these lesions do not really have a unified terminology. This is our study. You see that we see in subset of them all single basal cells that are P63 positive, and all of them have a gastric-like mucin profile and the same mutation, but no P53 mutation. So really it looks at these are precursors of the mucinous adenocarcinoma and not part of the spectrum of adenocarcinoma itself. You see here Also, the Japanese study showed exactly the same, and only in those that looked malignant, it might be expected to have the p53 mutation. All these cases did not have p53 mutations. They have just AKT1 mutation. So this lesion has been, after a long discussion, put into the so-called controversial category in the WHO classification that is immediately now expected. So it is not clear if they are related to adenocarcinoma. I would say it is clear. They are related to it, but as a precursor lesion. Are they part of a single spectrum? I don't know what they mean with the spectrum. In the colorectal carcinogenesis, we have the tubular adenoma, the tubulovillous, and then the invasive carcinoma. All are on the spectrum. However, you put the line between adenoma as non-invasive benign condition and adenocarcinoma as invasive aggressive condition. So these lesions are really related. The same thing if you look at colorectal adenoma, you will find ABC mutation, maybe plus or without other additional mutations. When you go to the adenocarcinoma component, you have more genetic aberrations. So this is really a benign precursor, I would say, of these mucinous adenocarcinomas. Now, very briefly, sinonasal classification has been very much changed and updated. Now, for the first time, we have a genetic-based definition of these poorly differentiated carcinomas. We know already the nut carcinoma, now Swiss-Nif complex deficient carcinomas are included, which include SMARCB1 and SMARCA4 deficient types. Sinonasal lymphoepithelial carcinoma is already known. It is genetically or etiologically defined by EBV infection, and SNUC is now a diagnosis of exclusion. There are new genetic data in teratocarcinosarcoma. HBV-related multiphenotypic sinonasal carcinoma is now not a provisional entity, but a definite entity. And there are some new data in these adenocarcinomas. I cannot go into these details. Now, just I show you one example of SNUC, which it looks like a large cell undifferentiated malignancy with nesting and very prominent nucleoli or macronucleoli, brisk mitotic activity. They usually express only pankeratin, but no squamous or adenocarcinoma markers. They may have, of course, some degree of neuroendocrine triads. Always think of this. It is not new, it is well known, but please always think of not carcinoma in any poorly differentiated cytologically monomorph sinonasal malignancy that is cytokeratin positive. You see, it looks like a large cell undifferentiated malignancy, very distinctive punctate nuclear expression of the NUT antibody. Many people just look after these classical or almost pathognomonic squamous differentiation or abrupt squamousness. However, these are almost pathognomonic, not really pathognomonic, but very specific to this entity. However, they are seen only in 43% of cases. So you cannot rely on them. You miss half of the cases if you just go by this. The same thing applies, by the way, for P53, 63 and P40. There is a subset, not really very small, of nut carcinoma. They lack these squamous markers. So just if you have any suspicion, just stand for the NUT antibody. They have a very variant morphology. The very small monotonous lymphoid-like cytological pattern can be very misleading, very poorly cohesive, no stroma at all, as we see here, or a mucoid myxoid stromal reaction in this case, which is from the larynx. So very small cell-like with mucus stromal reaction in the background is very suggestive of nut carcinoma. This is a very SNUC-like, very large cell pattern with macronucleoli, was a sinonasal case. We have to think of it. This is a salivary case. You see extensive neutrophilic reaction. It looks like poorly differentiated carcinoma. So always we have to think of nut carcinoma in any of these. Now, moving to the next genetic category, which is the Swiss-Nif deficient sinonasal carcinoma. To summarize this, Swiss-Nif complex is a gene complex with several components. The most important for us is SMARCB1 and SMARCA4. These are tumor suppressors, so the mutation is inactivating. It results in loss of the protein, so don't use positive SMARCB1 or negative SMARCB1, say deficient or proficient, because otherwise it can be misunderstood. So the same way we use for mismatch repair protein in colorectal cancer. So if you said it's INI1 is positive, I don't know, you mean the test is positive, so it is deficient case, or you mean it is histologically immunohistochemically positive, so it is retained. So this is one of the entities that I was also, again, lucky or our group to be the first one to describe it, followed 2 months later by Dr. Bishop, published in the same issue at that time of ESP, and later we pooled a very large series on 39 cases of these tumors. These tumors, most of them, 2/3 are very basaloid looking. They may look exophytic, endophytic, papillary-like. So this pattern, you don't need a dissociated invasion. This is an invasive malignancy in the sinonasal tract. It looks very much basaloid, non-keratinizing. However, you don't see classical squamous cell features, very dysmoblastic hysteroma in this infiltrative area. And sometimes it may look very undifferentiated or even rhabdoid cell containing. So this is one of the tumors that are relatively more aggressive than others. 1/3 of cases may have a more eosinophilic oncocytoid morphology. Unfortunately, because of time, I cannot go into the details. And you can verify them. The best sensitive, the most reliable test is the immunohistochemistry for SMARC-P1. All of the normal cells are positive. The neoplastic cells are completely negative. You can do FISH. You may see, of course, biallelic deletion of the green signals, which are the SMARC-B1 gene signals. However, the genetic is not that sensitive because we have different types of mutation or alteration that may be missed by NGS or even missed by FISH. So immuno is the most reliable and sensitive tool. Another variant on the same spectrum show unequivocal gland formation, either with tubule formation or cribriforming or cytoplasmic and extracytoplasmic mucin or yolk sac-like features or endometrioid-like features, and they have been now separated as SMARC-B1 deficient adenocarcinoma. They are different from the previous variant, mostly in that they are much more common on male, and they are much more common in the major nasal cavity, not in the sinuses. This is the main difference in them. Immuno is really very misleading. They co-express a lot of markers, including CK7, may show CK20, CDX2, P40 or P63, and CK5. And all of the yolk sac tumor markers can be variably positive, but usually very diffusely positive is SAL4. So if you think of a yolk sac tumor, you may be misled by this. However, they are really different from genuine germ cell neoplasm because they are usually disease of adults. You see here an example, eosinophilic adenocarcinoma-like or even some intestinal-like features, as you see here. So please always check for SMARC-P1 and not immediately go for CK20 and so on, because this can be mistaken for adenocarcinoma intestinal type. You see here pseudocribriforming, again here, and mucicarmine stain highlighting the mucus droplets. Some of these tumors may rarely show secretory endometrium-like features, also one of the patterns seen in yolk sac tumors, of course. So we have to be careful about this. And as I said, SAL4 and glypican may be very strongly positive. And this is the least common variant. This is one of the cases I have seen a few years ago, completely devoid of any other component, just looking like reticular microcystic yolk sac pattern. And if you look exactly here, you will see that it is a very bland looking, however, still it is an aggressive neoplasm, variable expression of CK7, AFP, glypican, and diffuse SAL4, and this is SMARC-P1, which is completely lost. And by the way, all genuine germ cell neoplasm, this irrespective of type, they do not have any Swiss-Nif alteration or SMARC-B1 loss. The next type of Swiss-Nif deficiency is the SMARC-A4 deficient category, which is mostly put into two categories. One of them is defined by the SMARC-A4 loss, that is SMARC-A4 deficient undifferentiated sinonasal carcinoma. The other one is the SMARC-A4 deficient keratocarcinosarcoma, which is defined not by SMARC-A4 loss, but by morphology, still because it is a multi-phenotypic malignancy. You see here This is much more large cell or rhabdoid or undifferentiated looking, which is in contrast to the most frequently basaloid looking SMARCB1 deficient type. Sometimes we may say small cell-like or even neuroendocrine-like component, and similar to SNAC, these tumors are the least differentiated. They do not have any squamous features or any glandular-like elements by immunohistochemistry. CK7 is usually negative, as well as P63, P40, and CK5. Pankeratin is usually variably positive, and SMARCA4, as you see here, is lost. So you can go to this review that we published recently in Advances in Anatomic Pathology to see how the comparison between the different entities in the historical SNAC spectrum can be separated from each other. SMARCA4 deficiency has been recently described by our group in the majority of sinonasal teratocarcinosarcomas. 82% of cases show variable degree of loss, most of them complete loss, and 15% show variable partial loss. And interestingly, cases studied by a very huge gene panel, they do not have any additional mutation, but only SMARCA4 gene mutation. So this means this is the sole driver of this multiphenotypic malignancy. This is the classical example of this squamoid differentiation with clear cell embryonal type, squamous epithelium, gastric type, foveolar epithelium, neuroectodermal, small round cell component, strap cells indicating rhabdomyoblastic features, and clear cell embryonal type tubule, as well as you see here. And again, you see either complete loss of SMARCA4 in all components, or sometimes you have very small foci of neuroectodermal type aggregates that still retain some degree of expression. This is just an overview to show you how you can try to separate this tumor from each other. You just put them into two groups separated by a line in the middle, into those with squamous-like immunophenotype or without. And if they have immunophenotype that is more squamous looking, then these are the major categories: poorly differentiated squamous, lymphoepithelioma, not carcinoma, and SMARCB1 deficient carcinoma in the majority of cases. If they lack this, we usually have either the classical SNAC or SMARCA4 deficient, or neuroendocrine carcinoma, poorly differentiated, and 1/3 or so of SMARCB1 deficient carcinomas. Now I can close up the sinonasal chapter with a few words on this emerging entity or provisional entity, which is DEC-AFF2 translocation associated sinonasal carcinoma, which is now included in the emerging category of non-keratinizing sinonasal carcinoma as a subtype. This was described for the first time 2020 in a single case report, and later into a larger series, maybe 2 or 3 series in total have been described. This is one of the series we pulled into 13 cases, also again collaboration series with Lisa Ruba and Justin Bishop. And these tumors are very interesting because they are most frequently seen in the sinonasal tract and less frequently in the temporal bone where they first were reported. The nasopharynx and orbit can be involved. Middle-aged patients are affected, and there is anecdotal description of enhanced response to immune checkpoint inhibition therapy. So it is important to recognize them, and also because they are more aggressive than classical sinonasal squamous carcinoma, they metastasize frequently to distant sites. They have usually a combination of endophytic, exophytic, papilloma-like growth with mostly transitional cell-like morphology, no keratinization, no pleomorphism, and usually there is excessive mainly granulocytic intratumoral and stromal background inflammation, which is the best clue for diagnosis. Viruses are not detected, and the diagnosis is the differential is mostly non-keratinizing squamous cell carcinoma with transitional-like features or carcinoma ex papilloma. And indeed, if you go back, you find that half of your cases were initially called inverted sinonasal papilloma. You see here example of them. They are very papilloma-like, transitional epithelial-like, basaloid-like, or sometimes slightly pink stain, and even this is the most impressive type that you can diagnose by H&E. It looks like transitional epithelium, but with this very excessive neutrophilic reaction in the background. This is the last part I just like to address in 1 or 2 minutes. Now we have a separate section in the WHO classification on soft tissue tumors that have a strong predilection for the head and neck. These include classical entities like lipoma and many other variants of it that are mostly seen in the head and neck. However, we have 2 new kits on the block. This is one of them is phosphaturic mesenchymal tumor and GLI1 altered soft tissue neoplasm, because these really are under-recognized by head and neck pathologists because they are not usually included in that book. And now I am sure that many of the head and neck pathologists not familiar with soft tissue pathology will start to learn and recognize them because they are included in the book. This is an example I have seen recently, polypoid ulcerated epiglottic mass in an old male. It looks really very much like lymphoepithelial-like carcinoma or poorly differentiated malignancy or lymphoma with this sprinkling of lymphocytes. However, keratin was negative, P16 very positive, P53 mutated type, all other markers are negative. And indeed, the clue to this diagnosis and how you recognize them, you can include always these 3 markers. If you see this type of STAT6, which is very specific nucleocytoplasmic, this is never seen in SFT or other STAT6 translocation tumors. This is a typical pattern of amplification, and you see the background is very clean. The neoblast, the vascular cells, stromal cells are not stained. The neoplastic cells look like P16 immunohistochemistry or like CDK4. Again, this is a co-amplification, and very few cells may be MDM2 positive, and this tumor is caused by frequent co-amplification of 3 to 5 genes that are located on chromosome 12q 13 to 15 band, and diagnosis can be made by a combination of morphology, immunophenotype, and even molecular testing. And now there is also a new antibody that detects GLI1 in the nuclei and cytoplasm of these cells. This is the literature due to a short time I will overjump this. However, you know that we have 2 types of GLI1 altered neoplasm. One of them have the translocation or fusion, and one of them have the amplification. And if we look here, I put this some times ago together, but it does not include all of the reported cases because after this table, 2-3 series have been published, and you see that indeed almost 1/3 of the cases in both the amplified and the fused arm of this entity are head and neck based. So we have to be really aware of them in head and neck pathology. This is an example of the fusion positive, more in neuroendocrine-like, more glomoid or uniform, and the amplified variant is more nested, more atypical looking, or more less differentiated looking. Impressive is this multinodular plexiform growth. When we see something like this in the tongue, in the submucosal tongue, this is almost pathognomonic for GLI1 amplified mesenchymal neoplasm. This is an example of glomus tumor that can be seen in the salivary gland and rarely in other head and neck sites. It's completely different from the GLI1 altered, and you see diffuse SMA and collagen 4, which is a distinctive feature of this entity. Pseudoendocrine sarcoma is a recently described entity with nuclear beta-catenin expression with beta-catenin mutation, may have some pseudomonas microcalcification. However, most of them occur in all the adults in paravertebral side. So if you see something like this in the head and neck, it is very unlikely to be a pseudoendocrine sarcoma, but more likely to be a GLI1 fusion associated neoplasm. So this is just the last topic I like to discuss, and I thank you very much for the invitation. I mean the organizers and you all for your kind attention. And unfortunately, I will be at another meeting, so I cannot attend the live streaming of the course. So if any question, you can contact me by email or by any other tools. Thank you very much for your attention.
Okay, so Go ahead, Dr. Mudassir, you wanted to say something?
Okay, now the Umar will start the next meeting.
Sure. Okay, thank you so much, Dr. Agemi. That was a very comprehensive review of the updates of head and neck tumors. So now we will proceed with our last lecture for today. That is hepatic cyst subclassification and clinical characteristics by Dr. Khalid Amin. So we will proceed with the lecture.
Assalamu alaikum, everybody. Today I'm going to be discussing classification, differential diagnosis, and clinical pathological characteristics of hepatic cysts. Hepatic cysts are increasingly being detected in the liver due to widespread use of imaging. And actually, their prevalence have been reported to be as high as 18%. In the literature, there are highly conflicting reviews on the relative frequency, clinical features, and biological behavior of different types of hepatic cysts. This is mostly because of the lack of uniform definition and consistent terminology for various types of hepatic cysts. Most importantly, the term hepatobiliary cyst adenoma is often used as an umbrella term to designate a spectrum of processes ranging from reactive lesions to neoplastic, thus leading to conflicting views regarding their nature, prognosis, and management. In fact, WHO recommends that cyst adenoma or cyst adenocarcinoma term to be avoided altogether in order to avoid this confusion. In the meantime, significant developments have taken place in the classification of other cyst-forming biliary interductal neoplasms, such as interductal papillary neoplasm of the bile duct, interductal tubulopapillary neoplasm, and the interductal oncocytic papillary neoplasms. These tumors are now classified into specific diagnostic categories rather than the previous non-specific name of cyst adenoma or cyst adenocarcinoma. The nature of non-neoplastic biliary cyst is also becoming increasingly unraveled. These include congenital cysts such as choledochal cyst, biliary hematomas, and polycystic liver disease, most of which continue to be misdiagnosed as hepatobiliary cyst adenoma because of lack of recognition of the WHO criteria. Some of these entities are now better defined because of critical radiological assessment by MRI and pathological correlationing. As a result, entities like cystic giant complicated bile duct hematoma have been delineated. Congenital cystic lesion of the biliary tract constitute a group of primary benign biliary disorders arising from a continuous spectrum of duct plate development anomalies, also known as duct plate malformation or fibropolycystic liver diseases. These entities may involve both intra or extrahepatic bile ducts and may exist as individual conditions or in combination, which suggests their common origin. This constellation of congenital disorders includes Crowley's disease, Crowley's syndrome, choledochal cyst, autosomal dominant polycystic liver disease, congenital hepatic fibrosis, and biliary hematomas. In order to better understand the duct plate malformations, I am going to briefly delve into basic embryology. This schematic diagram of biliary system delineates embryogenesis and malformations. The biliary system actually originates from a single layer of duct plate that surrounds the portal vein. It later evolves into a cylindrical double-layered epithelial structure, which subsequently undergoes remodeling and partial involution. Different fibropolycystic liver diseases results from interruption of this process depending on the stage of embryological development in which the defect occurs. This process of remodeling and involution actually starts from the hilum and progresses into the liver. If it is interrupted earlier on, then the large ducts will be affected. And the diseases that result from this include choledochal cyst and Crowley's disease. If the medium-sized ducts are affected, then the disease that is caused is polycystic liver disease. If this process is interrupted later on, at the end, small ducts are affected. And the diseases that are caused include congenital hepatic fibrosis and biliary hamartomas. Autosomal recessive fibrocystic disease of the liver and kidney are caused by germline recessive loss of proteins required for function and maintenance of the primary cilium, and therefore are called ciliopathies. There are many disease entities in this, but the one that affect the liver includes 3 phenotypes, which likely represents a continuum. And they include congenital hepatic fibrosis that leads to progressive fibrosis of the portal tract, the Crowley's disease, characterized by large intrahepatic bile ducts that are dilated and form cystic structures, and the Crowley syndrome, which is a combination of Crowley's disease and congenital hepatic fibrosis. Congenital hepatic fibrosis in isolated form occurs in about 10% of the cases. In more numerous cases, actually, it is associated with Crowley's disease, and it is therefore called Crowley's syndrome. And it is characterized by enlargement of portal spaces due to presence of abundant and irregular fibrosis around the portal tracts, with numerous dilated abnormal bile tracts that communicate with the biliary tree. On gross examination, if you see a liver affected by congenital hepatic fibrosis, it looks just like cirrhosis. And it is characterized by this nodular gut surface. On microscopy, it is characterized by irregular islands of hepatocytes that are separated by with very dense fibrous stroma, which contains these irregular duct profiles. And on this high power image, you can see that these bile ducts are very irregular in contour. Some of them might show some cystic change, and they are separated by dense pink hyalinized stroma. Crowley's disease is relatively rare autosomal recessive congenital disease, and it is characterized by a secular dilatation of large intrahepatic bile ducts that typically communicates with the biliary system. Another characteristic of these ducts, as in some of the of these dilatations of these cysts, is that sometimes you can see fibrous strands traversing through the cysts. On imaging, the presence of these fibrous strands create this characteristic central dot sign on CT. Crowley's disease is also associated with high incidence of intrahepatic cholelithiasis, cholangitis, and hepatic abscess. Interestingly, cirrhosis and portal hypertension is absent. On gross examination, the liver is typically, it shows variably sized cysts that are dilated, and they seem to follow the portal tract. Over here, you can see a cyst that shows these traversing fibrous band that contain portal vessels. This is the trichrome stain that shows fibrosis along these cysts. However, the degree of fibrosis is significantly less than what you see in congenital hepatic fibrosis. This is an H&E image that shows dilated cyst-like structure containing inspissated bile, and it is lined by bland cuboidal to low columnar epithelium. In many cases, you will see surrounding inflammation, which is not seen in this particular case. This is a core biopsy that shows these dilated cysts over here, indicating Crowley's disease. And over here, if you look at it, the morphology is more in favor of congenital hepatic fibrosis. So this is an example of Crowley's syndrome. So autosomal dominant polycystic liver disease is a hereditary condition associated with duct plate malformation originating at the level of medium ducts, resulting in large fluid-filled epithelial cysts throughout the liver parenchyma. This can occur as isolated form with hepatic involvement only, or it may be associated with autosomal dominant polycystic kidney disease, which happens in about 80 to 90% of cases. Occasionally, it may be confined to one or more hepatic segments. Isolated form of polycystic liver disease is commonly associated with mutation of the gene, with this brackish gene, which encodes for a protein called hepatocystin. This protein has shown to have a role in regulation of cyst formation. The variable number, size, location, and distribution of cysts determine the spectrum of symptoms, which are often related to extent of hepatomegaly. The clinical features of the autosomal dominant polycystic liver disease include pain, which is due to increased tension on the Gleason's liver capsule, abdominal distension due to voluminous cyst resulting in compression and displacement of the adjacent abdominal organs, or signs of liver and kidney failure. Hepatocysts in this polycystic liver disease are thought to arise from von Meyer-Berg complexes or biliary hematomas, and most of these do not communicate with the biliary system. The diagnoses include the autosomal dominant polycystic kidney disease, and it's important to differentiate the isolated form from this, because the isolated form that only affects the liver has a better prognosis and is clinically less aggressive. Also, you have to, since you can see a lot of biliary hematomas in this, it is important to differentiate it from these biliary hematomas, because these are basically benign and have no clinical consequences. Over here, you can see a liver that is affected by this polycystic liver disease. As you can see, there are variably sized cysts. Some of the liver over here is spared. On microscopic examination, you can see that around these large cysts, you can see some bile duct hematomas. Over here, some of the cyst lining is denuded, and the cyst wall shows hyalinizing fibrosis. Over here, this high power image shows the cyst lining that is composed of these very bland appearing cuboidal epithelial cells. So choledochal cysts include a wide spectrum of abnormalities characterized by congenital dilatation of large extrahepatic ducts with or without involvement of the intrahepatic ducts. The classical triad of pain, mass in the right upper quadrant, and jaundice is seen in about 1/3 of the patients, of pediatric patients. Actually, in pediatric patients, jaundice is far more common. And in adults, the more common presentation is in form of ascending cholangitis. 80% of these patients are female, And in up to 60% of cases, choledochal cysts are diagnosed before the age of 10. MRCP represents the best imaging modality for the diagnosis and subclassification of choledochal cysts. This is the Tudani's classification, which shows different type of choledochal cysts. The type A cyst causes cystic dilatation of the extrahepatic bile duct. The type 1B shows focal and segmental dilatation of the extrahepatic bile duct. In type C, there is a smooth fusiform dilatation of the entire extrahepatic bile duct. In type 2, there is a diverticulum. The cyst is actually the dilatation is in form of a diverticulum. In type 3, type 3 typically involves the intramural part of the common bile duct, where you can see a choledococele, which is protruding into the duodenum. In type 4, there is dilatation of both extrahepatic and intrahepatic ducts. In 4B, it is only the extrahepatic bile ducts that are dilated, but it is multifocal. Type 5 is also called is basically Crowley's disease that result in intrahepatic dilatation of these ducts, large ducts. On microscopy, most of the time you will see that the lining is or is ulcerated. You might not even see the lining. The lining is typically bland and biliary type of epithelium. Sometimes it can be associated with intestinal metaplasia, and it can also be associated with dysplasia. The complication of choledochal cysts include cholestasis, biliary stones, biliary strictures, cholangitis, pancreatitis, and secondary biliary cirrhosis. However, the most important complication to recognize is the increased risk of cholangiocarcinoma, which actually increases with age. In the first decade, its incidence is less than 1%, but in later decades, it can be up to 15%. The type 1 choledochal cyst carries the highest risk, whereas the type 3 has the lowest risk. Bile duct hematomas are actually quite common, and they are also called von Meyenberg complexes. They have been found to occur in about 0.6 to 2.8% of population, and they are caused by interruption of the remodeling of duct plate in the late phase. Clinically, they remain asymptomatic throughout the life and requires no management, no histological confirmation or follow-up. And they are typically followed up, basically. On imaging, they are characterized by small lesions, less than 1.5 centimeter cystic lesions that are sharply delineated and uniform in size, and they are scattered throughout the liver parenchyma. Also, there is no increased risk of malignancy associated with von Meyenberg complexes. However, they can be seen in other chronic liver diseases. The main differential diagnosis on imaging is sometimes they can be confused with liver metastasis. And they are difficult, actually, they can be challenging to diagnose on ultrasound and CT. The best modality to diagnose biliary hematomas is MRI, where they appear as small, less than 2 centimeter cysts that appear hypointense on T1 weighted images and hyperintense on T2 weighted images. And also they are characterized by this thin peripheral rim of enhancement that is typically less than 2 millimeters. And on MRCP, they have this characteristic starry sky appearance, which is caused by small hyperintense lesions scattered throughout the hepatic parenchyma. On gross examination, on the gut surface, they are sometimes difficult to recognize, but on the capsular surface, as seen over here, they can be seen as white spots. And characteristically, you can see they show these biliary duct-like structures, some containing inspirated bile. Over here, on high power, you can see that the lining is basically composed of these bland cuboidal biliary type epithelial cells. This is a bile duct hematoma seen in a patient of Hep C with cirrhosis. And as I mentioned again, that it is not uncommon to see these associated with other liver diseases. The complex large and hepatic biliary hematomas. This is relatively a new entity, and it has been proposed actually by a couple of papers that were published recently by Dr. Edsey, who's one of the hepatobiliary and pancreatic pathology expert. And these are actually characterized by dilated cysts that are often associated with presence of regularly appearing bile duct hematomas, and these cysts can have surrounding inflammation and they can have hemorrhage. And characteristically, they have very characteristic MRI findings where they can be lobulated. They are typically larger than 2 centimeters and can have hemorrhage. And they also show a thick peripheral rim of enhancement, which is greater than 2 millimeters. And that can typically develop after percutaneous intervention. Over here, this is the MRI images that show this large cystic and complex biliary hematoma, which is characterized by a presence of these fluid levels. On H&E, you can see that there's a cystic dilatation over here, with surrounding hemorrhage over here. And over here, you can see the morphology, which is that of a typical bile duct hematoma. This is the post-contrast image that shows basically presence of this small biliary hematoma with peripheral enhancement. Simple biliary cysts, which are not otherwise specified, are quite common. Dr. Edsey et al. In 2 of his publications suggested that at least a subset of these NOS-type biliary cysts can be called as giant, complicated, and cystic version of bile duct hematomas because of recent radiological pathological correlation studies. And he actually proposed that these to be referred as duct plate malformation cysts. And the reason again is because these cysts are often associated with, or they often show a transition to von Meyer-Brunn complexes, and they often show bile duct hematomas in the background liver, and specifically on MRI. Here's a table that summarizes various duct plate malformation and fibropolycystic liver disease. Again, the Crowley's disease and congenital hepatic fibrosis or autosomal recessive diseases that results in the mutations in genes PKHD1. And then the autosomal dominant polycystic liver disease and the autosomal dominant kidney liver disease, which is actually can both occur together. In the isolated form, the liver disease actually is associated with mutations in several genes, as mentioned over here. And interestingly, all of these diseases are associated with presence of von Meyerberg complexes. Next, I'm going to discuss the neoplastic cystic lesions of the liver. And there are basically four entities that I'm going to discuss in this category. And the first two lesions, the mucinous cystic neoplasm of liver and the intraductal papillary neoplasm of the bile duct, are more recognized and more common. The next two entities, the intraductal tubulopapillary neoplasm of bile duct and the intraductal oncocytic neoplasm of bile duct, are relatively, these are newly recognized entities. Cystic change in cholangiocarcinoma or metastatic carcinoma can also occur and can present as a cystic lesion of the liver. Mucinous cystic neoplasm was actually initially termed as biliary cyst adenoma and biliary cyst adenocarcinoma. This entity was reclassified as MCN by WHO in 2010, and furthermore defined MCN by presence of ovarian-like stroma, which is critical for diagnosis of this entity. Before the WHO 2010 classification, MCN could be reported without the presence of ovarian-like stroma. And the distinction between intraductal papillary neoplasm of bile ducts, other cystic tumors with mucin-producing epithelium could be challenging. And interestingly, the absence of ovarian stroma was thought to be associated with worse prognosis at that time. These tumors, clinically, they present as abdominal pain or with abdominal distension, and more common. They're more common on the left hepatic lobe, and on imaging, they are characterized by a presence of mostly multilocular cyst, solitary cyst with cyst and cyst-like appearance, and it does not communicate with the biliary tree. And there also could be, they can have internal septations and have thick fibrous capsules. On gross examination, they are typically solitary multilocular cysts with septations. 10% can be unilocular. On average, they are quite large, greater than, they can be up to 30 centimeters in size. And they are typically filled with mucinous bile-tinged fluid. The inner surface is usually smooth and trabeculated. Rarely, papillary mural nodules can be identified. On microscopic examination, they can be actually lined by an array of different types of epitheliums, ranging from cuboidal to columnar. They can have cuboidal biliary type epithelium and or mucinous type of epithelium. In some cases, you can only see biliary type of epithelium. So that is why it is very important to look for the ovarian stroma that will give you the diagnosis. And this ovarian stroma is typically positive for estrogen receptor, progesterone receptor, and alpha inhibin. The incidence of dysplasia, of high-grade dysplasia, is actually low. Most of them will have low-grade dysplasia. And the risk of invasive carcinoma is also quite low compared to other type of intraductal pre-invasive neoplasms of liver. They also have a characteristic molecular profile. About 20% of these show KRAS mutations. And the cases where KRAS mutations are seen tend to be more multilocular, and they have higher grades of dysplasia. On immunohistochemistry, they are typically positive for MUC1, MUC2, and MUC5AC. As compared to IPMNs, they don't have any gene-as mutations. The differential diagnosis of MCN includes interductal papillary neoplasm of the bile ducts. Both these lesions can present as cystic masses with mucin production and actually cannot be distinguished by imaging studies. Rarely, MCN can cause dilatation of the bile duct, and it can mimic an interductal papillary neoplasm radiographically. But again, the main distinguishing feature that is seen on histology is presence of ovarian-like stroma. Simple biliary duct is also an important differential diagnosis. As I mentioned earlier, many of these MCNs can sometimes show only presence of only biliary type of epithelium. And you would not see the characteristic, mucinous epithelium. So therefore, it can be sometimes mistaken for simply biliary cyst. Again, to avoid this misdiagnosis, the best thing is to do extensive sampling and detect the ovarian-like stroma. Over here, you can see an MCN, which is showing this multilocular cyst with fibrous walls. This is the cyst lining. In this one, the cyst lining is composed of bland type of low columnar to cuboidal epithelium with basally polarized nuclei. And over here, the classical ovarian stroma highlighted by estrogen receptor immunostain. And in some cases, you can see high-grade dysplasia and associated invasive carcinoma. Interductal papillary neoplasm of the bile duct. This is more commonly seen in males. The average age is about 50 to 70 years. And the risk factor for this entity includes hepatolithiasis and certain parasitic diseases that include liver flukes. Clinical features include intermittent abdominal pain, acute cholangitis, or jaundice. But in some patients, there are no symptoms. Their location is mostly intrahepatic, and they can occur more on the left side. And they can also occur in extrahepatic bile ducts. And the most common findings on imaging include bile duct dilatation and interductal masses. They are typically single or multiple polypoid exophytic masses arising in bile ducts that are dilated. If you look at the mucosa, it can show granularity with formation of small papilla. And these masses are quite friable and actually may slough off. And then they can also cause biliary obstruction with accumulation of thick mucin. Because of this obstruction, they can also, they cause cystic or aneurysmal dilatation of affected bile ducts. And in some cases, they can occur without visible mucin hypersecretion. And actually, on microscopy, this epithelium can be very similar to what you see in IPMN of pancreas. It can be of gastric type, which is more common, intestinal type, or the pancreatic biliary type. And the dysplasia for this entity is graded on two-tiered scheme, where low-grade and intermediate dysplasia is labeled as low-grade. Also, there's a high incidence of malignancy and with this interductal papillary neoplasms. And it can be as high as 80% as compared to only 50% for IPMNs. Also, the prognosis is also worse as compared to IPMN, 69% versus 87% for IPMN. A recent large study by a Japan-Korean cooperative group proposed that the interductal papillary bile duct neoplasms to be divided into two types based on the clinical pathological features. The type 1 primarily occur in the intrahepatic bile ducts, and they are associated with frequent mucin production as opposed to type 2. On histology, they are complex with solid and cribriform architecture. Type 1 has gastric and intestinal type, while type 2 has intestinal and pancreaticobiliary type epithelium. Type 1 is mostly high grade, with 20% showing low grade cytology with less common stromal invasion, seen in less than 50% of cases, and thus have more favorable post-operative course. The type 2 are almost always, they have high grade dysplasia, and about more than 80% are associated with stromal invasion, and thus more aggressive with worst outcome. And this is the characteristic morphology of the interductal papillary neoplasm. And over here, you can see three different type of epithelium. And this is the pancreaticobiliary type, which is the most aggressive type of epithelium, or which is mostly associated with high grade, and it is characterized by formation of these micropapilla that contains these very pleomorphic cells. This is the gastric foveolar type, which is quite bland, and it is, as you can see, it shows the basal localization of the very uniform nuclei. Over here, this is the intestinal type. That over here, it is showing a tubulovillous adenoma-like architecture, and it is characterized by presence of these penceroid cells. And also, you can see some abnormal appearing goblet cells. The differential diagnosis of interductal papillary neoplasm of bile duct includes bilin or micropapillary biliary intraepithelial neoplasia, and it also includes interductal tubulopapillary neoplasm, which is a relatively new entity, and it is the architecture. This neoplasm will show mostly tubular architecture, and also it has a different immunoprofile. It is typically negative for MUC5 AC. And also, the differential diagnosis includes metastasis from extrahepatic organs, colorectal carcinoma being most common, and also intrahepatic cholangiocarcinoma can also sometimes come in the differential diagnosis. These are these two entities over here. This is the interductal tubulopapillary neoplasm that form this cast-like lesion. But again, the main thing to recognize and differentiate this entity from interductal papillary bile duct neoplasm is presence of this very tubular architecture. This is an intrahepatic cholangiocarcinoma that has undergone cystic degeneration. There's a lot of necrosis over here that you can see. However, the characteristic papillary architecture is absent. The interductal tubulopapillary neoplasms are relatively newly recognized entity. They are more commonly encountered in women. They occur in the predominantly in the intrahepatic biliary system, and they're thought to arise from peribiliary glands through a T53 KRAS independent mechanism. They are typically MUC5 AC negative, and they are positive for MUC6. And on imaging, actually, they can show features that mimics an obstructive lesions. They can be mistaken as calculi, or sometimes they can cause obstruction with upstream dilatation, and can resemble a malignant tumor. On gross examination, they typically appear as gas-like lesions. Over here, you can see that this is a hemorrhagic lesion that is filling the duct. They can also present as multinodular interductal masses with only focal cystic change. This is the characteristic morphology. As by definition, they should exhibit a tubular configuration, which is seen over here, without any significant papilla formation. They can also be associated with necrosis, as seen over here. They are composed of non-mucinous cells or cells with minimal mucin production that form back-to-back tubular units and by default qualify as high-grade dysplasia over here. And in some cases, neoplastic tubules have eosinophilic intraluminal content that resembles thyroid follicles. This is a table that actually shows the differential diagnosis of these 3 pre-invasive neoplasms of the bile duct. Again, for interductal tubulopapillary neoplasm, you have to basically recognize the tubular architecture with minimal papilla formation, and typically they will not show much mucin production. And the cytology of the cells is usually very high grade. For the interductal papillary neoplasms of bile duct, again, there will be predominant papillary architecture with formation of mucin. And although many of them will show high-grade dysplasia, but a significant number will have a low-grade dysplasia. Also, these entities have different profiles on immunohistochemistry. So interductal papillary neoplasm of bile duct can be associated with, have an increased association actually with carcinomas. Over here, the 2 types of actually carcinomas can arise. The more common are the tubular type, as seen over here, and less common are the collar type with production of mucin. And you can see the mucin, the cells floating in this mucin pool. Interductal oncocytic papillary neoplasms were actually initially, they were classified as a subtype of interductal papillary neoplasm by WHO 2010. But in 2019, WHO reclassified IOPNs as separate neoplastic entity. And this is actually because of many reasons. One of them is they have very distinctive, morphology on microscopy. And also recently, there have been studies that have shown some very interesting novel mutations in these neoplasms. And these actually, the most interesting mutations that have been described are actually in the BRCA A and B genes. And in subset of these cases, the mutations were identical to what we see in the fibrolamellar variant of HCC. So that is why these are now, this is now a totally separate entity. And it is characterized by presence of these complex papillary structures that are lined by these stratified epithelium, which is very oncocytic. And in many of these nuclei, you can see a very prominent nucleoli. Also, another characteristic of these is presence of these intracytoplasmic lumina. And over here, you can see a associated collar-like carcinoma arising from an IOPN. Last, I'm going to discuss gynococcus cyst. So this cyst is actually, in 90% of the cases, it is caused by gynococcus granulosus. and in small percentage, it is caused by Echinococcus multilocularis, which cause alveolar hydrated disease. And this is a very interesting case that we recently saw. And this is the aspiration cytology of the cyst that was done. And it shows the characteristic feature. Over here, you can see Scolex, degenerated inflammatory cells and other type of parasitic cells in the background. And these characteristic hooklets that we are seeing that has a Schmitter sword-like appearance. And also you can see some laminar fragments of the cyst wall. These are now treated by a novel technique, which is called the pair technique. They are first, the cyst is aspirated and re-injected with hypertonic warm saline, and then re-aspirated. And this is the classical findings of both types of hydrated cysts. In the first image, this is a T2 weighted MR image showing giant cystic liver mass with multivesicular vesiculated honeycomb-like appearance. And this is a gross image that shows this onion skin-like multi-layered membrane. And over here is the histological image that shows the various membranes or various linings of this hydrated cyst. This is Echinococcus alveolaris. Actually, this subtype can be can have imaging characteristic that can mimic actually cholangiocarcinoma. This is on this axial post contrast T1 image. It shows a large nodular complex mass with findings which are highly concerning for malignancy. And on macroscopic examination, there's a sclerotic, irregular, and infiltrative edges that creates a picture that is indistinguishable from a cholangiocarcinoma. On microscopic examination, it is characterized by inner germinative membranes of the organism with the surrounding granulomatous and inflammatory reaction. In the last, I will just recap everything. And this is a very nice, actually, differential diagnosis algorithm that was published in one of the papers by Dr. Edse et al. And over here, the main thing is that if you if you receive a liver cyst, first of all, see if there's any epithelial lining or not. If it is not lined by an epithelium, then it could be, a echinococcus cyst, an abscess, other form of inflammatory or parasitic cysts, or it could be a hematoma. If you find an epithelial lining, then the next most important step is to identify ovarian type stroma. If ovarian type stroma is identified, then it is a MCN or mucinous cystic neoplasm. If no ovarian type stroma is identified, then it could be a non-neoplastic cyst, which includes cystic bile duct hematoma, which will have characteristic, radiological findings. It could be a NOS type biliary cyst, which is quite common, or it could be acquired cystic dilatation of the bile duct, or it could be a congenital cyst such as colorectal cyst. If you see non-biliary type of epithelium, flat, very benign type of epithelium, then it could represent basically a mesothelial or foregut type of cyst. If it is non-MCN, then the main thing is, first of all, make sure that you're not dealing with a malignancy with cystic degeneration, and that is typically not that difficult. If you determine that this is an interductal neoplasm, then based on the morphology, it can be put in any of these three entities: the interductal papillary neoplasm, which can have gastric, intestinal, or pancreatic biliary type morphology, the interductal tubulopapillary neoplasm with primary tubular morphology, and then oncocytic, the IOPN interductal neoplasm of bile duct, which will have characteristically oncocytic cells.
Okay, so with this last talk, I think we have concluded this pathology session of this year's symposium. And the questions should be sent to the respective speakers. Actually, all the speakers, they were from, not all, but only one was from Europe, and next were the rest of the people were from America. So right now they are not live with us. So we'll send this questions to those speakers. And thank you very much for this worthy audience and the people who are online, and all the speakers and the administration of this Shaukat Khanum Hospital, Peshawar and Lahore, for this magnificent symposium. Thank you very much. All the best.